Hello, I am Alexander Zajac, and this is Beckwith-Wiedemann Syndrome. Beckwith-Wiedemann Syndrome is principally a pediatric overgrowth condition. The development of the syndrome is the result of multiple genetic causes, and thus expression of the condition is highly variable among individuals. In addition to growth dysregulation associated with this condition, there is also an increased risk for tumor development in affected individuals. Background and prevalence. So background, this syndrome was originally identified in the early 1960s by doctors Beckwith and Wiedemann themselves. They even had the privilege of naming this syndrome. And since then, we've been researching and refining the diagnosis. Current prevalence is estimated about 1 in 10,000 live births. We think this is likely an underestimate, as milder expressions often go undiagnosed. Now, there is an increased prevalence up to 1 in 1,200 with assistive reproductive technology, such as in vitro fertilization. But other than that, there's no association of sex or race other than female monozygotic twins. And there doesn't seem to be a consensus regarding the mechanism why this is more common in female twins rather than male twins, but some hypotheses are this could be a consequence of more developmental errors in females, or it could be lethal for affected male twins. Phenotypic expression and presentation, highly variable. So I'll go over some of the most common and defining features of Beckwith-Wiedemann syndrome. First is macroglossia, a very large tongue. This is a little more specific to Beckwith-Wiedemann syndrome than some other phenotypic expressions. So if you see this, that should maybe clue you in, this could be Beckwith-Wiedemann. Omphalocele, this is a herniation of the abdominal contents into the umbilical cord. This is usually associated with other syndromes and birth defects. So sometimes an omphalocele is nice because you can look for other things, especially things with the vertebrae or the heart. In the case of Beckwith-Wiedemann syndrome, during normal fetal development early in pregnancy, the abdominal contents develop outside of the body. And if they grow too much, sometimes they'll stay there and won't be able to move back in. You could also see umbilical hernia in affected individuals because there's just so much stuff in their abdomen that it outpouches just a tad. Hyperinsulinism, this will manifest as hypoglycemia, of course, in the neonatal period, and this could be a consequence of an enlarged pancreas. Macrosomia, greater than 97th percentile for weight, along with hemihypertrophy. Both of those associated with the overgrowth condition, but hemihypertrophy is overgrowth of one side of the body, or at least one part, like an arm or a leg. But it demonstrates laterality. That can be another thing to clue you in to Beckwith-Wiedemann. And of course, tumors. If you see a tumor, Beckwith-Wiedemann syndrome should maybe be in the back of your mind, especially if you see it with other clinically suggestive features. Here's a picture of an affected child with Beckwith-Wiedemann, and I'd want to highlight two things for you here. First, you see the enlarged tongue, the macroglossia. That takes up a lot of his mouth. And then on the left side here, you see a little bit of that hemihypertrophy. You can see that left side has just a little bit more mass than the right. Diagnosis can be challenging. There have been a lot of articles and authors that have suggested scoring based on clinical presentation of individuals, giving some more points for some features like macroglossia and then fewer points for others like hyperinsulinism. Genetic testing can also be helpful in establishing a diagnosis, but positive genetic testing tends to correlate with the more overt clinical presentation anyway. Furthermore, genetic testing so far has demonstrated positive results in only about 80% of cases of Beckwith-Wiedemann, and therefore a negative result also doesn't, or I should say doesn't necessarily exclude a diagnosis of Beckwith-Wiedemann too. And this is just one author that proposed a scoring system as an example, and they compared their scoring to the likelihood of a positive genetic test. And you can see the more questionable a child's syndromes are, the less likely you're gonna have a positive result for Beckwith-Wiedemann. And as I just mentioned, a negative result doesn't necessarily exclude a diagnosis, so sometimes not of the greatest diagnostic utility, but it is something that could be utilized. Genetic involvement, principally 4 genes of particular interest in Beckwith-Wiedemann syndrome, and these are genes that are implicated in cell growth. First, IGF-2, insulin-like growth factor. You may remember this from earlier in the course. H19 is a gene nearby to insulin-like growth factor. We don't know for sure what it does, but we think it's probably tumor suppressive. CDKN1C. This could be the most likely gene of the 4 that I'll discuss here that results in the phenotypic expressions that we see. The gene helps control growth, especially prior to birth during fetal development. And then KCNQ1OT1. This regulates other growth genes. Genetic mechanisms. In principle, alterations of expression on chromosome 11p15 can result in some of the Beckwith-Wiedemann syndrome phenotypic expressions. And this is mostly a consequence of abnormal methylation and imprinting. So some epigenetic insult or otherwise some other epigenetic factor triggers methylation in imprinting regions on the chromosome, which in turn cause a failure to regulate gene expression of the 4 genes I discussed on the last slide, which therefore results in overgrowth. And over 50% of Beckwith-Wiedemann syndrome cases can be associated with this sequence. Uniparental disomy, specifically paternal uniparental disomy. This explains about 20% of Beckwith-Wiedemann syndrome cases. This will usually occur early in embryonic development and will therefore see mosaicism. And when this happens with chromosome 11, we can see some expression of Beckwith-Wiedemann syndrome. Point mutations in CDKN1C especially have been observed in affected individuals. And then any other gross abnormalities in chromosome 11, such as translocation, duplications, and deletions. This can result in non-functioning genes or genes that are not there. Genetic inheritance, 85% of the time, this doesn't demonstrate any inheritance pattern. Most commonly, this is just a result of the epigenetic changes and insults, or the uniparental disomy that ultimately result in the abnormal methylation. 10 to 15% of the time, you could observe an autosomal dominant inheritance pattern. And this is typically inherited from the mother, but inheritance of the trait on occasion won't result in expression. You can have a child that tests positive for the trait, genetically, in other words, and still appear as a well normal kid. Management of Beckwith-Wiedemann syndrome, I can boil it down to 2 things for you to remember. First thing you'll want to do is tumor screening. You'll want routine ultrasounds through the age of 7, particularly abdominal and renal ultrasounds. then you'll want to consider alpha-fetoprotein screening through age 4. Most of the time, the renal and hepatic tumors will develop in the first 7 years of life. So this is what guides recommendation for screening during this time frame. Second thing for management is fix whatever's causing the problems. Most important is to treat the tumors if they're identified, but some other expressions can warrant your attention. For example, if a newborn is born with an omphalocele, that omphalocele is going to need to be reduced in the neonatal period. And then macroglossia can result in airway compromise, which could require surgical intervention if it's bad enough. And then something like hemihypertrophy could be an indication for orthopedics involvement. In regards to ethical, legal, social, and financial issues, there are only a couple of considerations. There's the potential for airway compromise, which can result in hospitalization. And then there's the predisposition to pediatric cancer, which can also result in hospitalization. But outside of these concerns, prognosis for affected individuals with the syndrome is really quite good, as long as they are managed appropriately and they're screened appropriately. These are my references.